Hey, folks, if you haven't done so already, please click that subscribe button below. That'll help us grow as a show, attract better guests. Together, let's make healthcare better for everyone. Once again, click that subscribe button. We'll see you on the next one.
Get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and today's guest is a visionary leader at the forefront of healthcare transformation. Keith Pinter is the Chief Executive Officer, the CEO of AristaMD, company revolutionizing specialty care coordination and empowering primary care providers through innovative technology solutions. With over 25 years of experience in healthcare and technology, Keith has a proven track record of leading companies through rapid growth and developing novel business models to meet clinical and financial needs. Prior to AristaMD, he co-founded Rise Health, a value-based primary care platform, and served as Chief Operating Officer for Envision Physician Services, where he was instrumental in scaling the organization from $800 million to $6 billion. Underachiever. Recognized as a 2003 Entrepreneur of the Year by Health Insights, Keith is committed to improving clinical outcomes and patient care through technology enablement. Keith, welcome to the big show. How are you doing?
Ray, I'm thrilled to be here.
Right on. Hey, it's great having you. So, at the end of the day, you've done a lot. You've had a pretty illustrious career, and I always kind of start out in the same spot with my guests. Like, no one kind of chooses this path.
Yeah.
Did you from like an early age, did you know you'd be here?
Oh, heck no. Dude, I'm not even sure that at a late age, with the different stuff I've done, that I'm where I need to be.
Yeah.
But I do know where I'm at is we're making a difference, in healthcare. So like the first part of my career, I began, in the technology side of things and did a bunch of sales stuff and then ultimately progressed into operations and then bought and sold companies and said, okay, can make a pretty good living doing this. But being a father.
Now wait, you're a Denver guy. I thought all tech happened in San Francisco or New York.
Well, I did spend a bunch of time in SoCal.
Okay.
So raising the family, we actually moved from the Midwest out to SoCal for one of the early internet organizations. Actually, there are 5 companies that commercialized DARPANET, which is the internet of today. So the 5 ISPs, I happen to be a part of one of those. So I really saw what commercialization of novel technologies. Holy crap. I mean, back then we're like, oh yeah, what can you do? Well, you can do email a little more, right? Who would have thought that it fundamentally would change everything in how we do, right? And once you have the capacity to do things, it's amazing the other opportunities that came up, the other efficiencies that came up, right? Everything from, you go from thinking about like an ISP, an internet service provider, and providing, access and a broadband access. Once people have that enough, then they start to buy more online, and you see the growth of like an Amazon, and then how Amazon displaces in person, right, and makes it so much easier. You go to some of the ride sharing apps, and by the way, you all need less cars and more people need to ride share here. Being a Denver guy, too few mountains and too many people in cars all the time.
Listen, New York has its pros and it has its cons. And I will tell you, you're right about the cons. Like, definitely we could do better with having more bikes on the streets.
Yeah.
But it's also pretty risky riding a bike in New York City.
Dude. Yeah. And there are certain months of the year,
yeah,
it gets even worse.
Yeah.
Yes.
No doubt.
So it's just seeing things from, the what technology did and thinking about, how technology solved a business problem. It wasn't technology for the sake of it. Applying that mindset, and I said, I really want to make the world a better place. I want to make a difference, not just make money. Healthcare continued to stand out because most people say that healthcare technology or the use of technology in healthcare is like 10 to 15 years behind like mainstream business. So something that, is 1/5 of our GDP, that is 10 to 15 years behind. And by the way, 1/5 of our GDP, people are like, yeah, but we got the best healthcare in the world. Actually, a majority of the data says that our outcomes are in the bottom third of the world.
And no one believes that. If you talk to the, the
Yeah.
regular man on the street, so to speak, America's the best. And I love that. I love the nationalism. I'm a pro-America guy.
Amen, dude. Amen.
I 100% like, freedom and what we've been afforded.
Yeah, life,
and
liberty,
our,
the pursuit of happiness. Amen.
it doesn't get any better. But the harsh reality is that when it comes to health outcomes, yeah, we spend more than anybody else, but the quality side of the coin, it's just not there. And all the data points to it.
Yeah, well, and to your point, most people don't think about how bad it is. Yet when you get older, or when you know somebody that's ever gotten sick and they're over 60 years old, and they've had to advocate for themselves at every step of the journey, whether it was getting pre-authorized to get, to actually get a procedure paid for that your doctor said you need to have,
right?
Fighting on that, to getting into a hospital, to getting out of a hospital, to getting care while you're in there, to then after you leave, what do you do with it? And then, wait, I was in for this thing, but I've got 15 other things, and they all kind of link together, like comorbid conditions.
Yeah.
So, I think that if we talk to people that were over 65 versus people that were in their 30s, 40s, or 50s, after they've experienced the system a little more, they go, you know what? I probably can't disagree because my personal experience was pretty bad.
Yeah.
Right.
Yeah. Well, we're mechanical beings, right? And guess what? Shit breaks down.
Yes. Right.
Right. Wear and tear. It's especially, you mentioned to me, we were having a conversation before the podcast that you're into skiing and downhill skiing.
Yep.
Well, and you're into the bumps. That takes a toll. Like, I haven't asked you about knee surgeries or anything like that, but I'm sure there's some wear and tear on them knees.
Yes, sir.
And the older you get, it's inevitable. Even if you take good care of yourself, even if you're fit and you're doing all the lateral exercises that you should to prep for, ski season, and, you're living in Denver, you're probably doing that all year round.
Yes.
But at the end,
I should be.
At the end of the day, if your ski catches a rut and, you zig when you should have zagged, and, it's just like physics, something somewhere has got to give. Yes. The next thing you know, you hear a pop.
Wait, you were with me on the hill the other day, a couple of years ago, and I blew the ACL and heard that famous pop, and then realized I wasn't invincible. What? You probably haven't gotten that realization yet.
And we didn't even have that conversation, right? So it's just it kind of comes with the sports. Like, if you practice jujitsu, you're going to get injured. It's right. part of the game. But at the end of the day, you're exactly right, because I think depending upon where you are in life, your experience interfacing with the healthcare system is going to be very different. If you're blessed with good genetics and you're lucky to avoid injury, you're in your teens, 20s, 30s, even 40s, you may rarely go to the doctor, if ever, right? Yeah. And we're not here to talk about kind of, what the Millman guidelines are for standard of care and how often you should have your annual physical and do the mammogram and stuff like that.
I heard that there's a cheat code with that, the annual physical. Is that one time a year?
Supposedly, but it depends on who you ask. So, but at the end of the day, we're spending a ton of money per capita for healthcare, whether you use it or not. And I was thinking about this the other day. I knew I was going to have you on, and I was starting to think to myself, it's crazy because right now, if, the majority of folks in the U.S. get their coverage through their employer, the working force, so not the 65 and above crowd, not the folks that are covered by the military, the TRICARE folks, not the Medicaid folks, but the majority get their coverage through their employer. That represents more than all of the other coverages I mentioned combined. And we have the privilege of spending, in the New York City metro area where I'm from, kind of in the ballpark of $30,000 a year for the privilege of having an insurance policy. And I'm thinking to myself, so my doctors are affiliated with NYU. If I go on the NYU portal and try to set an appointment with my primary care physician, How long do you think it takes to get an appointment on average?
Between 30 and 60 days.
Yeah. So if you get an appointment within 90 days, you're lucky.
Okay.
And if that 1 or 2 days that's available in 90 days is not available, we could go out 5 or 6 months. So what's wrong with this? And so, being a businessman and being a numbers guy, I'm asking myself, well, if the coverage costs, in our case, maybe $40,000 a year, how much is that per appointment?
Right? And you're like, wait, why is it costing me so much to not have an appointment? Right? Yeah.
The math just doesn't work.
Right.
And it goes to your point of, and I don't even think the studies are necessarily even considering how long it takes to get an appointment. Maybe they are, but I think the studies of where the U.S. ranks has more to do with outcomes.
It does.
And it's reinfection rates and mortality and stuff like that.
Well, and to your point about, we as a population age, no kidding, right? Everyone ages. As a population, we're living longer, and our bodies weren't designed to live, as long as people are living. So they're naturally breaking down. So this idea that we spend a lot to not use healthcare, e.g. the insurance policy, right? When we're in our working years.
Yeah.
Then when we get to that point in time where we're supposed to be enjoying life, the retirement years, the utilization of healthcare goes up dramatically because our bodies aren't designed for it. Kind of the sins of the past. Not that, I've had a few million of those, that down the road, they catch up.
Yeah.
Right. And then getting in to see somebody, and then we make that a little bit more challenging, right? By, oh my God, now I got to go get in a car. Well, I may not be driving, or I may not want to drive. Then I get in, then I got to go have some tests done. I go to see my doc. He says, you know what? You need to go over here and get these tests done, and then come back and see me. And then I get the tests done. I don't really know what's happening. Doc calls me a couple of weeks later, 3 months later, I'm back in seeing them because it took so long to get an appointment. We didn't get all the tests done we needed. We're going to send you back. And it's just such a vicious cycle. And
right.
The ability to use, as we were saying earlier, technology, right? Like virtual care, one of, I think the neatest outcomes, if you will, from COVID was the acceptance of telemedicine, the ability to actually, regardless of your age, be talking to somebody like this and to do a video chat or to just be talking with them. All of a sudden, I don't have to wait as long to get an appointment. I don't have to go through the hassles of getting in, right? And then I may be a little more judicious in, why do I need this test or that test, right? And we've shortened the time period, right? And especially as we get older, the anxiety factor of not knowing what's happening with me, and then that really messes with our body's ability to heal itself. Like all of these things that are negative, parts of our ecosystem can be addressed with technology.
Yeah.
And we're seeing the acceptance again, regardless, like the amount of senior folks that have gotten used to seeing their grandkids on a video chat or on a Zoom or something like that.
Yeah.
So they feel more comfortable. All of a sudden we're solving for, some of these issues. It creates a series of other issues, within the system. That we've got to think a little bit differently about, like quality of the consults, quality of the diagnosis. How am I getting the information back? How is somebody that, is spending 10 minutes on a call with me or 15 minutes on a call with me? How do I know that, like, they've got all my medical records? Like the stuff that we kind of feel good about when we're in person because we see like the note taking. We don't have that in a virtual world, right? And then how does that virtual information come back in so that primary care, who's supposed to be quarterbacking me and my health journey so I don't get worse and I eventually, have a good quality of life.
Yeah.
How do we get that information to them and get them to make sense of it so they can help me?
It's a real problem. I look at healthcare and I do believe that direct primary care is, I think it's cause for optimism, because I really believe that DPC it gets back to kind of what healthcare was meant to be, where you have a relationship with your physician knows who you are, their volume and their caseload is considerably less than in the traditional system, it's, typically a third or a quarter of the workload. So they have more time to spend with their patients. They're freed from the usual, nonsense that's involved with documenting every, dotting every I and crossing every T in a conventional system. And there's a lot to unpack with what you said. So if you think about, just let's put the patient first, which patient
Amen.
should always be first, right? In a traditional system, and the one that I described, if you have an issue going on, and we're all different personality types, there are a ton of us that are extroverted, and we just love the sound of our own voice. We're going to talk to everyone and everyone, and we're going to question everything, and we're going to make noise if we don't get what we want. And then we have, kind of the people that are in between introvert and extrovert who, may or may not say something. We have introverts that are just not, it's not in their personality type to question or, question what is appropriate for me. What is the appropriate amount of time for me to wait before I should be concerned because I have something going on with me? And I worry about those folks, right? Because there are people out there that maybe they have no cause for concern on one end of the spectrum, but maybe they have something that, it's not apparently time for an ER visit. And folks, I'm not encouraging anyone to run to the ER.
Yeah, please let me second that. We'll drop the mic on that. Do not run to the ER unless it's absolutely required.
Yes, if you have pain in your chest, if you have difficulty breathing, if any classic signs of a heart attack or stroke onset, yes, by all means, go to the ER. But if you have a hangnail, don't go to the ER. But I think there are folks that maybe be in those situations where they should be, demanding to be seen sooner. And maybe, signs of a heart attack or stroke is not what I'm getting at, but maybe someone has, I don't know, they have a spot in their arm and, 3 or 4 days pass and the spot doubles in size. And then a week goes by and it doubles in size again. It might be time to demand that your primary care physician make room to see you because you have something going on.
Yeah.
And so I think about that stuff and it kind of boils my blood because no one should be waiting 6 months, 3 months to get an appointment, to be seen. So how does AristaMD solve for this?
It's a great question. And I think just to back up one step on the, getting in to see my primary care doc, again, in AristaMD focuses on the senior population. So when we're younger, oftentimes we feel more comfortable taking more risks.
God bless you, by the way, the senior population. I'm almost there, folks. Where's my appointment? God damn it!
From here right up,
right?
As we're younger, we take more risks. We'll search out things on our own, right? And we're kind of comfortable being maybe in the wild, right? Letting to fend for ourselves. As we get older, we're not as much, right? And so the senior population gets the problem just multiplies because if I can't get into my primary care, once I do get into my primary care, I trust my primary care usually because I've worked with them for a period of time. The old Doc Hollywood, right? The primary care spend more time. They know me. I may even, God forbid, get a birthday card,
right,
or get a little call, right? That genuine relationship and that trust that's there. So when my PCP then I have that says, hey, Keith, I want you to go see, Johnny the ortho, Dr. Johnny the ortho, or, Dr. Susie, the cardiologist, I'm not going to think twice. I'm going to go do that.
Yeah.
But now Dr. Johnny doesn't know much about my history, and Dr. Johnny may not really know my PCP, but it's always kind of who, things went to.
Yeah.
Same with Dr. Susie and the cardiologist. So the PCP is one challenge. What Arista solves for is once I've gotten into my PCP and that PCP needs to do something with me, right? Should the PCP actually send me to see a specialist? So Arista, in a very base form on things, has what's called a peer-to-peer e-consult. So literally, the primary care does a little thing in their EMR. It's not like 50 clicks, it's 1 or 2 clicks. One of our nurses picks up the information on the other end, looks inside the medical record, can find out all the information about, then curates that or gets all that information to one of our specialists. We have, 72 different specialties and a couple hundred specialists that work for us across the country. We're able to get back within a day. Does Keith really need to go see a specialist? So the first thing is, how many of those people that were sent just out of, hey, you kind of have an ouchie over here, your elbow hurt or your knee hurt, or, Keith, you're a dumbass and you tweaked it again skiing, go over here.
Yeah.
Do you really need to, or, are there other methodologies, or is it just waiting, right? So the first is, if we can offload the volume of people that don't need to go to see a specialist and that don't need to see them live, all of a sudden we're creating capacity for the people that do need, the people that have that larger spot in their arm, right? Getting into that dermatologist, right?
Yeah.
So what we have this first level where we solve for that by doing that behind the scenes, which cuts in half or oftentimes 2/3 of the referrals of primary care referring out to a specialist.
Yeah.
2/3 of those aren't necessary. So let's get the people the right level, the patients the right level of treatment care, and let's make it easy for the PCP. Because if the patient is at the center, which we all agree they should be, if we're not making life easier and better for their caregivers, the system falls apart. And those PCPs are the lowest paid. They have to know everything, like a super broad segment, and then they got to be able to go deep. And so the whole thing is kind of broken. So Arista makes it easy to do this consult behind the scenes. And then let's say that I actually do need to see a specialist, that, the PCP is like, you know what, got that information back. Yeah, you are one of those third that need to see a specialist.
Yeah.
Okay. Now I still have to go through that physical process of like booking in and getting in, talking to them, playing phone tag. How do I get an actual appointment? Then all the tests, all the back and forth. What we then do at Arista is we do a virtual visit with some of the top specialists. So a patient could have access to the top specialists all under the moniker of their PCP. So it's not having to go to somebody new that they don't trust. It's all a white labeled service that we're doing because we believe in empowering the PCPs with the tools, with the data, so they can have, with the time they have available, the ability to care for and then give them the care teams. So we allow that, and that virtual care then takes things to the next level of who actually, needs to be talking to a specialist. And that specialist then may determine, they have to go in and see somebody. I'll give you a very interesting case in point on this. So talking to a good friend of mine who's a cardiologist, I'm like, how much of this stuff do you actually think in cardiology can be done virtually? He's like, well, and getting patients to adjust to it are two different things.
Yeah.
He's like, literally, Keith, more than half the appointments that I have with people I could do virtually, but they like me to pull my stethoscope out. Right. So, breaking through some of those barriers, that just takes time, right?
Yeah.
It's an evolution. But so we do the virtual side of things to get those people who can have everything done virtually.
Yeah.
And those that need to go physically then aren't taking up more space in an inefficient ecosystem with specialty care.
Yeah.
So the problem we really solve for is access to specialty care and making it easy for the PCP and the primary care docs that are managing in a value-based care world, or the primary care docs that are taking global risk, where they're no longer getting paid to see that patient coming in and kind of that, whatever that ouchie boo-boo was, whether it's huge on the arm or, whether it's whatever, but they're actually paid on the total cost of care, whether I'm in a hospital, whether I'm seeing a specialist, whether I'm having, surgery, all of those things. So those folks naturally want and need to spend more time with their patients to properly diagnose.
Well, it sounds to me like you're creating efficiency, right?
Well said. What you said. Yes.
Ultimately, if you don't have this model. People are, kind of they're interfacing with their primary care physician, who now is making a referral out to a specialist. And now the patient's got to go get on the calendar for the specialist, wait however long to see the specialist. And now we're also on the back end relying on the primary care physician, because in your example, the primary care physician is reaching out to you, the patient, saying, "Hey, how'd you make out, Keith?" And I'm betting that often doesn't happen because they just simply don't have the time to do it. And maybe some of these things, technology is helping with some of these issues, but think about the back and forth and how long now it takes for someone to either figure out that they are in that third that needs an intervention versus, the 2/3 that aren't. I'm interviewing Dr. Mary O'Connor, who is she was the former chair of the Mayo Clinic for osteo.
Okay.
And she is I don't know if osteo is right, orthopedic surgery. And so she essentially is an expert in her field. And I've heard her give talks where she said over 70% of patients that are referred, don't need an intervention. They don't need a surgical intervention.
Yep.
There are other
the treatment
methodologies,
right?
Yeah. And so by having a system that you're creating this efficiency in, it seems to me that you're serving the primary care physician, you're serving the specialist, you're serving first and foremost the patient, and that's huge. So,
well, can I extend that one
please.
more? So let's assume, so you hit it right, and when somebody goes to see a specialist, the specialist is documenting in their electronic health record, and they're putting everything in because they have to submit that in order to get paid. That information very rarely gets back to my PCP. If he referred or she referred me out to a specialist, that data oftentimes doesn't come back in, or the labs that they ordered, or any of the tests that were done, or pictures, the images or X-rays. So the primary care very rarely. Let's assume the patient actually got in to see a specialist. Let's assume the specialist did or didn't do an intervention. The likelihood that the primary care has all the information in there is very slim, or they have all the information on a timely basis. A year later, they may have it, but that's, so ex post facto, right? So after the fact, it's irrelevant. And yet these primary care clinicians are tasked with delivering that. So they're working with half the information they need. Right. So we're like just another broken link in a system. We talk about inefficiencies. So, maybe other labs are ordered. Maybe I don't really understand everything that's going on. And sometimes I, as a patient, don't remember everything that the specialist told me. Right.
Sometimes.
I'm like, it sounded good at the time. I took a note and I can't even read my note. Yes.
I've seen some studies, like people literally walk out of the office after they've gotten a rundown of what they're supposed to do. Their physician kind of decompresses them. Here's what you need to do. It's like in one ear and out the other. Like statistically, people are just not, I don't know if it's a mental block, or they're focused on, oh my God, there's something wrong with me, I'm in a doctor's office. They just don't get it. And it literally, like, the studies show 10 minutes after their appointment, they're not retaining, and therefore not following doctor's instructions. And so,
and the doctor doesn't know what they are or aren't doing, right? Because how do you monitor? How do you know if a patient, on a timely basis, how do you know if they're complying? Over an extended period of time, because they get worse, right? But how do they know, right? And if the patient doesn't retain, and and even if I as a patient think I am, and the doc's like, "Oh, tell me about your visit," and I'll tell him, but I can't remember everything.
Yeah.
It's when I look at one of the root causes of why the outcomes are as low as they are, we don't have this continuity of care. We don't have some of this care management infrastructure and framework built in where there's a more free exchange or timely exchange of relevant data
Mm.
built in. Now, with the advent of things like virtual care, there's some of those bridges that we used to think, will never be built, they've been built. We just have to start driving on them and say, okay, I need to change my route to do this because it is more efficient, as you pointed out.
Right. So now if I'm a senior and I have Medicare and I'm in a traditional system and let's say my plan is and the network is through Optum, where do you guys come in? Like, are we relying on the patient to understand that Arista is part of it?
Great question. This is all behind the scenes. It is completely transparent to the patient because, again, our customer, our client is the primary care practice, Optum practice.
Okay.
And then what we are doing is consulting either with that primary care behind the scenes with this electronic consult or an e-consult, or if we're doing direct-to-patient virtual care, we're doing it on behalf of that primary care doc, e.g. the patient never has to do anything different, never knows it's anything other than it's faster than having to wait and do all the stuff that we just talked about.
Right.
So it's the whole beauty is we believe that the PCPs are designed to be quarterbacks for care.
Mm-hmm.
So you got to build an ecosystem surrounding them that enables them to do it and make it easy for the patient to just do whatever the patient needs to do to be healthy.
Mm. Is part of the challenge educating the PCPs?
It is, and it's tough. I think the biggest challenge is if I'm a primary care doc, again, as I said, I got to go broad and I got to go deep.
Yeah.
And if I'm being paid in what most primary cares are today in a fee-for-service world, that employer population that makes up the vast majority of patients,
right?
I'm being paid in a way that says I've got to see like 3 to 4 patients an hour.
Mm-hmm.
3 to 4 patients an hour, and I got to do this documentation that really doesn't have a lot to do with clinical care. But if I don't do all this stuff, I don't get paid. So it's billing and collections, and I got to do that when I'm in like my personal time.
Yeah.
So an average PCP over the last 10 years, maybe 15 years now, has had to see twice as many patients as they saw 15 years ago just to keep their income the same, and they have to do all this documentation. So
where do I sign up for that?
Yeah,
Keith?
You're like, wow. And we wonder why primary care doesn't have people knocking at the door, when they're leaving med school. You're like, oh my goodness, this is a broken system.
Yeah.
Right. And we can fix it by just doing some things fundamentally different. So I think a fair amount of this, really is for docs that are practicing in a value-based care, and value-based care is primarily targeted towards the seniors.
Yeah.
Because there's risk stratification. There's a bunch of payment stuff that the government has done to make it easier to focus on long-term outcomes as opposed to short-term episodes of care. So the ability to take and build something that, people, I think you've seen the statistics that the last 6 months of the person's life is the costliest by far of any portion of it. So we're working with a population that is a high consumer or a high cost, whether they're consuming or not consuming immediately, and figuring how to do all of this in that world and giving the PCPs the time that they need and building an ecosystem for them. Then taking that framework and moving that into other payer segments like the commercial side or the most painful segment in many respects is the Medicaid, right? And, all the stuff that's going on with Medicaid and even some of the, the current administration's points of view on it, those folks are going to use the system in some way, shape, or form, whether they have insurance or not. And, when we're not taking proper care of them, they're going to use it at the highest cost point and at the highest cost channel.
Yeah.
So, we eventually need to get down to that segment of the patients that are, consuming services on a safety net basis, if you will, like through the federally qualified health centers.
Yeah. Yeah, no doubt. I think when I look at what's going on right now in government, people are up in arms, thinking, "Oh, it's slash and burn," and I don't see that. What I see is a system that is rife with inefficiency.
Yep.
And I don't think the focus should be, where we're denying care. I don't think that's what I don't think that's what the folks that are looking at this are thinking about. I think what they're thinking about is where is the waste, fraud, abuse, and
Yes.
inefficiency, and how could we get better at that? Because I do think that there's a ton of that, as particularly in the Medicaid program, and also followed shortly behind in the Medicare space. And so, yeah, as I look at, so educate me, because I'm much more familiar with the private sector than I
Okay.
am the Medicare sector. So
Sure.
in the private sector, I would hear what you're saying, and I would say, well, why would it make sense for Optum, which is the division of
Mhm.
United Healthcare, for-profit entity with a fiduciary obligation to their shareholders? Why would it make sense for them to partner with AristaMD? Because they are, so the two ways that primary care physicians are compensated are the volume of patients that they see, and RVUs, relative value units, and that's how often they refer, and what the price ticket is on what they refer within their own health system,
Mhm.
right? And so, if I'm hearing this, and I'm sitting in the C-suite at United, I'm like, oh hell no, Keith! Like, why the hell would we? Why we don't want to drive less care? We want to drive more care. Does that apply in your space or not
No,
so
I
much?
and I think it would be the general point of view is we want to apply the appropriate amount of care,
Mm,
right? And if we can remove, and let's just take the commercial segment for a minute. If we can remove some of those inefficiencies within that, so yes, Optum will have a group of contracted clinicians that are in their network to go to, and we've all dealt with that, right?
yeah,
Well, if most patients are frustrated because they can't get in to see that specialist in a reasonable period of time,
yeah,
right? And so the ability to solve for that in the shorter run ultimately takes a bunch of cost out of the system. So I really think that we're starting to see more recognition of that, and the importance of having safety valves and different ways to think about care. And that's the commercial side. On the senior side, on the Medicare side, we've got two segments. We've got the Medicare Advantage, which are folks that have taken out a private plan that covers what a Medicare Advantage, which when you're over 65, you're covered by Medicare. So Medicare Advantage is this private plan that generally gives you some other really interesting perks. Like when you're talking about the access to care, many of the Medicare Advantage plans will cover transportation, or they'll cover drug delivery or things to your home, and helping you with food. So those Medicare Advantage plans generally, give people a little higher level of care in the things that they need, and the need to be proactive in how they're thinking about things, right? Instead of just waiting to see the doctor until something bad happens,
yeah,
how do I make sure that I get into an annual wellness visit, that I listen, that I have the right type of follow up? So the Medicare Advantage plans do that, and if you, I've yet to see data that shows anything other than Medicare Advantage is the single most effective government plan that's ever been done. So when we look at the total cost of care, yeah, in absolute dollars, it's a big amount. But if you look at what the total cost of care is for the population under Medicare Advantage versus under Medicare, which is more reactive,
yeah,
it's fundamentally different, and it's not favorable. So today, I think it's like 52, 53% of the seniors are in Medicare Advantage plans. So we've actually seen it hit a tipping point of more than half, right?
mm,
So when you're in Medicare Advantage plan, sometimes you can't see the specialist that you want to see. Well, our hypothesis at Arista is the most important relationship that you have is with your PCP. Talk to your PCP, let your PCP help and drive you, and let's make access to care easier and more timely, and get the data back to your PCP.
mm,
So when I think about that in a Medicare world, the non-Medicare Advantage or non-MA plan side of things, those folks, they're like the equivalent of an Optum in United, because United gets paid by CMS, the government, to deliver care. And there's an actuarial analysis that says, here's what population costs, and then here's what you get paid and how well you do it. is how much it costs as a medical loss ratio, how well you do it, is more profitable, et cetera. The equivalent of a United in that example would be accountable care organizations. And in a value-based care world, sometimes those are called REACH ACOs or MSSP shared savings ACOs. They're the ones that are working with the groups, like a smaller version of an Optum, perhaps in a local marketplace, like a primary care group of 100 docs instead of 10,000 of the Optum size, right? Or
Right.
100,000.
Sure.
Right. So it's giving those groups the ability to have a different level of resources and to give them the ability to participate in the Medicare population in the longitudinal care costs, like how well they are delivering care over a year or 2 year or 3 year period.
Yeah.
So fundamentally changing things. So those ACOs and the REACH population specifically are really an interesting segment. And for those folks, it's the same thing. And there's a direct correlation because some of those networks aren't contracted for. So that's why we're focused in the senior space. And look, the biggest tells for satisfaction for us, we have a very high net promoter score or NPS from primary care docs that are using our system working for some of these other groups. So, it's above a 90. Which is very, very high. And people often say primary care docs don't like anything. Well, kind of because the world we said, you can't introduce something new into somebody that's already swamped and overloaded,
Right.
unless it really makes things easier or better. So the fact that it does that, and then we have their patients in some of the surveys have also a high net promoter score. So happy patients are healthy patients.
Yeah.
Right. Healthy patients usually are, a function of a PCP that is dialed in, that's able to do all the things in a time. And guess what? That PCP is probably a little bit happier with things. So it goes back to Dean Ornish, this whole idea of happiness. And if you can focus on doing these basic things to make a doc's life easier and a patient's life easier, and especially as they get older, their entire caregivers. I mean, if you could look inside or talk to the PCP or look into a record and see that your mom or dad actually had these things going on and here's what was happening. And by the way, they had a relationship with somebody that wasn't the doc, that was like a nurse practitioner or somebody calling them on a regular basis that they knew. And more importantly, when they had a little hiccup that they could call. I think that's where we move from being reactive, or at best, I think our healthcare system today is designed to be fast reactive, to being proactive. Who are the people that before they get whatever need to be coming in and have a regular checkup for a bunch of other things done so we can identify before they become really bad?
Yeah.
Right. And I think that's where we start to really move the needle when we think about value-based care, the ability to be proactive. Right. And then when we have the economic incentives aligned with that and some of the technologies, it's better for patients and it's better for the docs.
This episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. So what's some of the pushback that you hear, like the naysayers who, you're explaining this model to them for the first time, or maybe it's not the first time, maybe you're 3 or 4 meetings in.
Yeah.
What are I'm just racking my brain trying to figure out where are the holes in
the
this
friction
plan?
Maybe let's talk about friction points or abrasion points first, right? So first, if a group, if a primary care doc doesn't have, if they have to see 3 to 4 patients an hour, it just doesn't work for us, because even though they want to deliver the best in care, having to change anything in their workflow and doing it consistently, and then the amount of crap that they have to do from documentation to get any type of reimbursement, there isn't the reinforcement mechanisms there. So it's a broken ecosystem. So that's first and foremost. Now, for the docs that are working for these groups who are in value-based care, where they're encouraging spending more time, going back to the relationship side, going back to being proactive, then it's well, why would I do this? But I'm used to sending, my patients down to, Dr. Johnny But I've always done it that way.
Right.
Well, okay, so let's look at the data and say, okay, how did Dr. Johnny's outcomes fare? How was the patient satisfied? What was the total cost of care? And docs are the most challenging and the easiest group to work with when you go to change management. Presenting the data is the difference.
Yeah.
So it's saying, let's look at this. You care about the best in care. And yes, you play golf with Dr. Johnny, but that's really not the driver by why you're sending your patients, is it? I mean, come on.
Yeah.
Right. Here's a different way. And then getting a couple of early champions, right? We just need a couple of people like in a new organization working with us. Give us the most outspoken critics. Let us work with them on what could be done differently. And I'll give you a really interesting case in point. So when you think about, and to use the orthopedic example earlier, when you think about care and you think, hey, I got to get something done for my hip or my knee, I got kind of three choices. I can go get a procedure done. I can do PT or I can do nothing. Well, usually doing nothing is not the desired outcome. So, and if I don't want a procedure, now I've got to go do PT. Well, the hassle, again, let's go back to transportation challenge, the hassle of getting in, similar wait times, going to the PT, going through that process. Well, if somebody could do PT in their home, that would seem to take a lot of the inefficiencies out. The question is, what's the efficacy of virtual PT? So had a doc group in rural New Mexico, Harvard-trained doc that actually went back to help his community and deliver great care on a rural basis. So he's like, people aren't going to do this virtual PT thing. You got to be kidding. We're like, would you please try? He's like, fine, I'll try. Okay, I'm willing. I'm willing to be your guinea pig. 4 people. 3 of the 4 said, I'll try. We trust you, doc, going back to the relationship, right?
Yep.
All 3 of them are like, wait, I don't have to drive an hour to get to PT. I don't have to deal with this. Okay, I'll continue to try this.
Right.
So he's like, okay, maybe that's a weird sample size. Maybe we should try it with more. Similar responses.
Sure.
And then I'll take it one step further. In some of these rural areas, they don't even still have broadband that's adequate. So he took one of his exam rooms and turned it into a virtual PT room.
Yeah.
Okay, there's an example of behavioral change management, giving an opportunity to say, let's just try this.
Yeah.
Let's figure it out, right?
Time is the great equalizer, right? Let's ask Steve Jobs what he thinks about time, right? All the money in the world, phenomenal, iconic, legendary business leader of our time. But time is the great equalizer. And so if you could give people their time back, that's huge with the capital H.
And if you could give them a better experience for doing like the substitute product of having to go through all that, right? And then their level of satisfaction.
Yeah.
So I agree on the time, and I think the whole patient experience, is huge in all of this.
Well, so I think that's kind of where does it become important to have a trained professional's hands on you, and what do you do in those situations? Because I'm sure we've all torn stuff, and there are times when you need electro stimulation. I don't know the exact terminology, but and it's more than just doing some exercises.
Right.
It's and hopefully virtually you could be guided so that you're doing the exercises properly, right? But there are going to be circumstances where there is no substitute for going to a brick and mortar's place. And so how do you handle that?
Let's go back to the problem set that I think we're solving, that I know we're solving for, which is access to care. So if we say, based upon the availability of appointments, there isn't enough capacity today.
Yeah.
How do I free up capacity? So the first thing I do is I take to the Mayo, my colleague at Mayo's example, right? I take 2/3 of the noise out of the system.
Yeah.
I've created more capacity, and the beauty of virtual too is I can see people in easier intervals and I can plug them in different areas.
Right.
So I'm freeing up capacity. So then when somebody actually has to go in for a physical procedure or an intervention, there's more capacity and elasticity in the system. So, there's never a replacement for an absolute silver bullet for
But
replacing.
Keith, is it your specialist then that is referring them to another specialist, or does it go back to the PCP?
No, great example. So in this situation, so if we were managing your knee stuff,
Yeah.
15 years from now, when you hit that age of 65,
Yep.
that you were being covered by this, our specialist who had been working with you and who has the relationship with you and their nurse practitioner would simply say, you know what, we have a group over here
Yep.
that we'll move you into. Right. So again, we're not forcing it to go back upstream to the PCP. We are notifying the PCP so they're in the loop and they know what's happening.
Right.
But we're curating, we're getting that information, we're getting everything there. And then our care manager is also staying on top of all that, because just because you got in for a procedure, did you go in? Did you actually get it done? What did it feel like? What's the follow-up that needs to be done? Making sure those gaps don't exist. So
that's huge too, because the word that sticks out of my mind is curated, because without having a medical expert curate your care, you're Forrest Gump. Your life is like a box of chocolates. You never know what you're going to get, right?
Yes.
So if you're just picking a specialist amongst all of the specialties, specialists in orthopedics, for example, well, how do you know it's a good orthopedic surgeon if surgery is the indicated intervention? Right. And the average person doesn't have a clue. And Google is not there yet. The last time I checked.
Well, and the Yelpification of things, right, is not necessarily the right indicator, right? There's a substantial amount of statistical data that shows the highest performing specialists, that shows both in outcomes, in cost, in patient satisfaction. The average person can't get there. So they look at a Yelp rating. Well, we all know it's kind of wrong with that, right? Yet it's
Everything.
A data point, right? And it again goes to somebody being out in the wild, having to fight for themselves. So, having both the specialists get the right information and the right specialists. And sometimes we associate right specialists with likability.
Yeah.
So I'll give you a very interesting point. So a while back, I had 15 years ago, I had some heart stuff. And turns out I had an arrhythmia. So I went to an electrophysiologist, because you either have issues with plumbing or electricity in your heart. So electrophysiologist is hence the name, the electrical side.
Yep.
And a horrible bedside manner, just absolutely brutal. Like, 1, 2, 3, 4. I'm like, I don't really like you. Actually talk to the
So they did an EP study.
They did, the electrophysiologist.
And you had to be awake for that. They had to introduce adrenaline to look for the electrical short circuit if there was one. Yeah.
Right. And so you're like, you kind of want, it's a scary experience.
Yeah.
So you kind of I wanted somebody with a good bedside. Talk to my PCPs, like, look, let me tell you, this is the best guy. I've dealt with it. Here is outcomes. And by the way, if you need to have an actual procedure done, this guy does the most of them. Get over the bedside manner. If I didn't have that conversation and if my PCP didn't have the data, and by the way, I actually did have to have cardiac ablation done, and it was successful. So, again, when we look at a bias of how well I liked somebody, e.g. the Yelpification, it's really the wrong filter.
Yeah.
Which is why I bring it back to the PCP and how do you help them be that quarterback?
Yeah, it's a good example and one that hits home with me, and I'll share a personal story. Not me, my daughter. So my daughter had been, just kind of having tachycardia out of the blue. She's going along with her day, la la la, and her heart starts racing like she ran a sprint.
Yeah, like 150, 170 beats a minute type of thing.
Yeah, exactly. And so, we were like, well, that's unusual. That's odd.
Yeah.
And so took her to a local cardiologist. They put a Holter monitor on her and they were going to kind of track her for a while. And she kind of had another one. And I just called her checking up on her. I was like, hey, what's going on? She said, I said, how you doing? She said, not good, Dad. I said, well, what's the story? She said, well, I just, I'm at the checkout line at the grocery store. She walked there. It's not even half a mile from here. She said, I feel like I just ran a full sprint. So I was like, all right, we're going. Like, I'm not taking any chances.
Yes.
And so we go. And long story short, they advised to do an EP study. Now, in hindsight, I have several problems with this. So what's problem number one? Problem number one is while she was there, they didn't witness this tachycardia. So they kept her overnight for observation. Her heart didn't, do that so that they could observe it. So a little bit of a red flag there.
Mhm.
Number two, why not think about, I don't know, taking magnesium as opposed to rushing straight to an EP study? Because what folks probably don't know who aren't aware is that for this procedure, they're threading a catheter, through your groin, through your neck. They're looking at your heart. They're poking and prodding around your heart. And then they have to introduce adrenaline to see if they find this anomaly, like this extraneous tissue that is causing a short circuit, to use the electrical problem. And if they see it, they're going to ablate it. And you say, "Oh, that's a fancy word. What does that mean?" It means they're going to kill it. They're
Right.
going to
burn it out.
They're going to burn it. They're going to freeze it. They're going to cauterize it. They're going to ablate it. Gone. And so she's, now in her early 20s, never been hospitalized before, never been through anything like this. She has a doc who is her surgeon is an asshole. He's barking orders at his staff, and she's on the table like traumatized, from the experience. And so I happen to think, I believe, and I've not pursued this legally, and I'm not going to name the name of the hospital or the surgeon, but I believe that their ER is funneling patients into their EP lab. And why do I have this suspicion? Well, because of the things that I just mentioned, not kind of taking a more cautious approach. And by the way, the bill charges for the procedure was close to $200,000 for, an overnight stay in the hospital and, having this procedure done. So these are things that are broken in the healthcare system. And sometimes the scores, even this, because I know people in this business, and I had the doctor's scores, the surgeon's scores, and they were stellar. They couldn't get any better. But in the case of, you're a grown ass man,
Right.
and you didn't like what was going on. Imagine being a young girl and
Traumatized is the absolute right word.
right?
Right. And then hearing all that, then and was this really necessary?
Yeah.
Right. And I think that's where we will see, hopefully, more intervention, for lack of a better word, business intervention, by the current administration in looking at what is necessary.
Yeah.
Right. And it's a sad statement to think that people would create unnecessary procedures. Well, okay, a doc would recommend an unnecessary procedure. In the absolute case, yes. Sometimes because of medical malpractice insurance and having claims filed against you and all this other stuff, we've created this risk factor that if I, as a physician, don't do all of these things, I'm liable. So it's really a balancing act, within there. And, fortunately, docs go to school not to make a lot of money. And those that, were making a bunch of money aren't making as much as they were anymore.
Yeah.
And primary cares especially aren't. So we don't have some of the natural fleecing that happens within an inefficient ecosystem.
Yeah.
But trying to manage through all of that and what's necessary, it does, I think, come back to, again, I'm highly biased that didn't come across in the primary care, and giving them the time and the tools and the data and being able to look at things on a little longer term basis, and being able to understand what's happening and what are other tests and what are homeopathic, and how do you pull all those together in a plan and a treatment care plan, right? And then the doc isn't the one who'd actually be calling your daughter again. A nurse practitioner would be doing care management and case management, just talking. What are you doing? How are you doing with this? What have you thought about here? Let's do this. like having that trusted advocate and having a
It's
relationship,
huge.
right? Now that's a care team that's happening, right? And I think those are parts of it,
Yeah.
that need to be looked at.
I think that's huge because had we not had the system that we have, and had my daughter had the benefit of not her dad, who knows an awful lot about healthcare, but is far, far, far from an MD or a
Right,
surgeon,
right.
but having an advocate or someone who is in between your primary care physician and that surgeon or that procedure or that operation, it may give you information that would lead to a completely different outcome. And, luckily, thank God she's doing fine today, but she's still got, some PTSD from that experience. And to think though, and look, I have a neighbor that experienced the same exact thing, same exact procedure. She felt like after going through the EP study, she was no better than she was before. And that in her case, she swears that the only thing that helps her is magnesium. She takes magnesium on a daily basis and she has no issue. So,
Yeah.
I think when we look at, doctors and, particularly surgeons, to a surgeon, to a hammer, it looks like a nail.
Yes.
To a surgeon, it looks like surgery.
Yes.
They're trained to say, well, this should be, and listen, far be it from me to throw physicians and surgeons under the bus.
Amen.
I think the vast majority of them, are in it for the right reasons.
Yes.
But I think there's
a bias, right? Again, you're not, they're not aware of the bias, right? It's conditioning. It just happens over time.
Correct.
Right. And how do you stop that? I'm not sure you can.
Yeah.
If you're relying on a single source, like if I as a patient am only going to a specialist, and if I don't have somebody else there, as you said, like interpreting the data, looking at this type of stuff.
Yeah.
Right. And then, there's the group of people out there that are like, well, that magnesium doesn't make a bit difference. And here's all the fringe research. We're like, I got to tell you, even if it is the placebo effect, why do you care if the person feels better?
Sure.
And it's not doing anything else, and especially something like magnesium, right? And then, like some of these things, we can get so caught up in the framework of being right or wrong, as opposed to, wait a minute, why do I care?
Undergoing an invasive procedure should never, ever be step one.
Amen.
Unless we're talking about emergency intervention. And in this case, in my daughter's case, she was not, showing signs of her heart exploding.
Right.
Or,
right.
It was not impending doom. We had the luxury of more time. And I think if the focus was on what's in the best interest of the patient.
Yep.
And can we, take a more gentle approach? Can we take a more reserved approach? If that had existed, she'd be in a lot better place right now. Now, that's not to say that she wouldn't have needed an EP study and an ablation, because who's to say? We don't have a crystal ball.
Right. But don't make it the first option. Make it part of a progressively more interventionally oriented approach. Right. But if people don't know, right, and they do this, or like to the point when people go to the ER for something, the ER kind of has a prescribed set of things that people are sent to. Otherwise, they couldn't take care of anyone. They couldn't do it's triage. Right. It's not an in-depth analysis. It's triage based on what they know.
Yeah.
Right. So it's why, really like it's like the last resort for somebody to go to see your primary care one of 15,000 last plugs for PCP. Go and have an annual wellness visit done. Talk to your PCP, get this stuff figured out so you can get into a proactive treatment. And then when anomalies happen, they're the first line of defense that you go through. Right. And then only if they're not available, do you go to the ER. If they say go to the ER, then of course you get in your car or take the ambulance to the ER.
Yeah. So getting back to kind of objections for AristaMD.
Yeah, behavior modification is the biggest one. It does this first is, does this really work?
Mm.
Right. And then it's yes, here's what the results are in a physician satisfaction, patient satisfaction. Here are the economics. And then the easiest path is, let's work with a couple of your docs. First talk to our docs, groups of docs who have gone through this. And then let's take a couple of you and go through and experience it yourself.
Mm.
So it's one of those that we're very fortunate because of the way the company was built, the architecture of the technology, the interactions, and what we do or we don't make it difficult. Like EMRs are so difficult.
Yeah.
Anytime you have to interface or get data from it, they're just difficult.
Yeah.
Won't even go down that diatribe. And I'll just say, so what we've done is we actually have a nurse navigator, a group of nurses who will basically sit on top of a PCP's EMR. They get all of the access. We do all the things to keep the patient health information safe and secure, and we only get access to that which we need. But they'll go in doing something manually, pulling the right information from that electronic health record to put it into a curated set of data, which then goes to a specialist who can make the consult and make it more robust because they have, God forbid, all the information they need, right? So that to me is an example of how we've architected the company to make it easy for clinicians to say, okay, you know what? There's enough data that says that's probably worthwhile. Let's do this. And then we make the experience easier. And then over time, we deal with the back end with the technology integrations and everything else that needs to happen. So that's how we're addressing those things. Those are really the main two objections that we hear out there.
Yeah.
Other than the practice ownership or the leadership of the practice has a list of priorities that are, really long and broad, right? And you get put at the end of it, which, that's life. You can't be everything to everyone.
Right.
If there are larger groups out there that have solved for access to specialty care, kudos. I want to hear about it. I want to study the model to figure out how we can share that with everyone because we need to solve for that.
Yeah.
If you have an access to specialty care issue, this is one of the few viable solutions today that are out there for it.
Yeah. That last thing that you said sounds like code for BS.
Right? Yeah, right. I'm like, okay, yeah.
Right.
Hello.
We
yes,
already
I've
we already got this figured out. Well,
yeah, really. Okay, I can pull data that says you don't, but far be it for me to convince you. Let me insult you, and then please work with me. Right? That's a great way to win friends and influence people.
Is that why I'm not as successful?
You got to be careful on how much BS we call early, right?
Yeah, for sure. Well, so what do you think about the future? Where do we go from here?
I'm super excited, as I said, about seeing the efficacy of virtual care.
Yeah.
And what that impact is 5 years from now. To be able to have said, how much efficiency or how much capacity did we create? What did that do for getting patients in faster? What did it do for their total cost of care? What did it do for their satisfaction? So I'm super excited to see the continued work in virtual care. I'm more or equally excited to see the outcomes of some of these risk-bearing primary care groups and to look at them over a 3 and a 5 year window to say, wait, the medical loss ratios, I get paid a certain dollar amount to take care of the patient, how well I do it determines what kind of profit or a loss ratio I have. Over time, if we're seeing those margins becoming better and better, we know that the economics support the thesis that if you do more proactively, you're going to have better outcomes. Better outcomes result in lower costs and higher patient satisfaction.
Yeah.
So I'm interested to see that. And then finally, the patient engagement side of things. Again, as we're seeing more and more going on, with cell phones and with seeing what AI can do. So I'll absolutely go on the record and say, in my lifetime, and I'm way older than you are, I don't see a time where AI replaces a clinician. I see it where it augments, that it provides better data to the clinician based upon evidence-based care guidelines, as we're talking MCG Melbourne care guidelines, or based upon this data, here's a curated set of things clinician take a look at, or here's how you could prioritize doing those things. And we know it's going to help a lot in the administration in the back end. And then finally, here's kind of a SWAT at the EMRs out there. Like, we need to make it easier for docs to do what they do, which is care for patients, not do revenue cycle management, which is billing and collections.
Right.
So I look at what, some of the work that's being done with virtual scribes that are capturing the stuff and then making it easier for the clinicians, because you don't want your doc typing away, and you don't want your doc spending a couple hours at the end of the day documenting something that they can't recommend because they saw that much and getting burnt out. So I look at what AI can do in that, and I'm really excited, far more excited than I am. But why would you try to solve for replacing a doc? Why wouldn't you give the doc more time and more capacity and better data? Why wouldn't you augment? Come on.
Right.
What problem are we solving for?
Right. I agree with you. I think AI and technology, the implications for it positively affecting efficiencies, better patient outcomes. I see all of those things as possibilities. I really don't see much downside to that at all. A lot of people are up in arms about losing jobs, and it's gonna shrink the workforce. And maybe so in certain areas here and there. But I think the bigger picture is it's enabling us to do more, and I think serve people a lot better. So
agreed.
Yeah,
agreed. Well, I think the last thing for where do we go from here? I'm interested to see further studies in the Medicare Advantage side that continues to show, and maybe a different slice and dice of the data, how we're getting better with this, and how do our Medicare Advantage outcomes compare to those of other folks caring for a senior population. So let's do a ceteris paribus, right? Let's actually compare apples to apples and say, okay, in general, our system is the highest cost and the worst outcomes. Are there segments that we're doing it well? And what are those best practices? And what do we learn, and how do we extrapolate that?
Yeah.
Again, I think that's a general thing that it's just tough, because healthcare at best is fast reactive. That's called being proactive.
Right.
It's not in the DNA. Well, there's a new group of folks that are entering the workforce, that are in the workforce, that do think that way.
Yeah.
Right. So I'm excited to see what they do, and with some of these large language models. And you start to say, okay, hey, here's a different service delivery ecosystem that we can put together, and then let's try it. Right. Because, people try to say, well, yeah, but how do you scale for healthcare on a national basis? Why do I care about scaling right now? Let me solve a meaningful problem set locally. And if I do that enough, that's a far better model.
Yeah.
Because healthcare is largely local. So I'm excited about how we see those things coming together, and the new workforce that's entering in.
Yeah. Agreed. So Keith, how do folks find you?
Keith.Pinter at AristaMD.com. AristaMD.com. Hey, I spelled it right. Thanks, Mom. Did okay in some spelling bees, or Keith Pinter on LinkedIn.
On LinkedIn.
Yeah, which is the LinkedIn is the easiest that, many folks use. And I'd love to have conversations with clinicians that are thinking about these problems, or different perspectives on it, and how we can help make their lives better so they make their patients' lives better.
Yeah, I'm not hearing any cons. So really appreciate you joining us, educating our audience. I learned a lot today. At the end of the day, we need a system of efficiency. And you're describing a system where there is certainly a lot more efficiency, a lot quicker time to access care. And I don't see any cons with that, certainly. So thank you so much for making the trip and joining us, Keith. Folks, until next time, love always. Take care. Bye-bye.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.